Okay, so in early 2015, a group of health regulators in Ontario formed a working group to explore the idea of regulating clinics in Ontario where their members work. So we are now part of this group. As you may know, we just very recently joined in October of 2015. Council of the College made a motion and agreed on a motion to participate as a member of the working group. Some people might have asked the question, why are the colleges getting involved? What we can tell you is that we weren't asked by government to do this. It was something that came up amongst the colleges as they had identified through complaints and other feedback from members about concerns and questions that their members had, and we're going to go into that a little bit more further into the presentation. Essentially, the working group and the project came from the frustration in the colleges that we're often faced with complaints or reports about individual professionals where once we get into it and look a little further into the problem, what we identify is that the real issue lies with the place where they're working and not with the practice of the individual member. However, we don't have authority directly over the workplaces that are not owned or operated or otherwise controlled by members. And as a result, we found that often the situation was that we're unable to directly address what might be the real problem that's actually going on in the work environment. So this is something that has been identified by the various colleges that are part of the working group, and what we saw was sort of a natural growth of the working group as colleges started having this conversation internally with their members and with other staff, realizing that this is in fact something that appears to be systemic amongst many of the college's memberships, if not all of them. And I say if not all of them, some of the college's memberships, for example, say nurses or physicians, they're already very much regulated, the workplaces that they work in, such as hospitals. And so they don't see this as much. However, it does still certainly arise in those sort of situations or for their members when they're working in those non-traditional heavy hospital-based settings. So you'll notice from the working group that colleges like the College of Physicians and Surgeons and the College of Nurses are not official partners of it. And please don't take that to mean that they don't also think that there could be an issue in workplaces. It's that it just doesn't have potentially the same sort of impact on their members. So the working group has created a website for members and members of the public, and there is lots of great information that's on this website. So if you have not already done so, I would strongly encourage you to go onto the website and have a look around. The staff that have been working on this at the College of Physiotherapists have put together some very, I say, easily digestible information for people to look at. Of course, another important part of this is the consultation part of the website. So this webinar is one of a series of consultation events that has provided our members and the members of the other colleges and other stakeholders with opportunities to hear about our concept for clinic regulation, and perhaps just as importantly, if not more so, to get feedback from members and members of the public about just the concept in general, as well as what some of the proposed components are that we're looking at. So again, I would encourage you to go onto the website, look at the information, and in particular, if you've not already done so, to respond to the consultation survey that you can also access on the website. So, clinic regulation, what is this all about? It is about addressing systemic barriers to patient safety, quality care, and efficient use of healthcare resources in clinic settings. As you know, the colleges are here to protect the public. That is what we do. And again, as I alluded to earlier, what colleges have noted is sometimes in dealing with concerns from members of the public or even other members, we notice that there appears to be some gaps in our ability in order to protect the public as a result of some of these systemic barriers that exist just in the natural way in which businesses are set up, they're not always owned by members or controlled by members. And as a result, there have been some gaps or barriers to the work that we're able to do in order to protect the public vis-a-vis our members. What we have done and what we're going to get into in a few slides here is prepared a proposed model for clinic regulation, and I think it's really important to emphasize the word proposed. This is very much in its early stages, and it was created in order to provide a piece for discussion. We thought it would be more worthwhile if we actually had something with a little more meat on its bones to discuss, rather than just talking about some ephemeral concept that would be difficult for people to wrap their heads around. But again, I think it's really important that everybody understands this is very much in the early stages. There has not even been a decision as to whether or not this will even go any further than the consultation, because we really do intend to thoroughly review all of the feedback, both through the webinars, the town halls, and then all the feedback through the survey, to decide what we're going to be doing for next steps. If it looks like our proposed model or something similar might be a good fit for Ontario, then what we will do is make any improvements or changes based on the feedback to the proposed model, and then look to making a recommendation to the Government of Ontario for the regulation of health clinics in Ontario. So just an overview of what we're going to cover off today. So why clinic regulation? Why us? Certainly this question has been asked both within the colleges and within the colleges councils, as well as by members. Why the college is looking at this when we are talking about a gap really that's not with our members but with others. A little bit about the process of how we got here to date and where we're going to be going forward. The potential models, that's that straw dog that I referred to. The impact or possible impact on patients and of course members, and questions and discussion. So as you know, what we do at the colleges is we regulate our members. So what you see here is a depiction where the regulated health professional, or RHP, is in our sites. That's who we regulate, that's who we license, that's who we are able to have some influence and effect over, as you know. It becomes much more difficult or much grayer when we're talking about the environment all around our regulated health professionals and the environments in which you work. As I mentioned, some of the environments that members work, both our members and others, are already quite regulated. So hospitals, for physicians and nurses and dietitians and all the others, of course, that work in hospital settings. Pharmacies are very much directly regulated under its own legislation, so it's not just the pharmacists but the pharmacies themselves that are subject to specific legislation. Out of hospital clinics for physicians who are performing services out of hospitals, those are specifically regulated, etc. And there are a few others. There are some types of regulations that apply to dental offices. They have certain equipment, that sort of thing. But certainly what we do know, and many of you probably would work in environments that are not subject to any other specific legislation that looks at the operation of that setting as a health provider. I mean, of course, every environment is subject in part or in whole to certain types of regulations like workplace safety and insurance, WMIS if you have chemicals, so workplace health, health and safety, and you know, you have obviously obligations with respect to billing if you are involved with billing with OHIP, that sort of thing. But otherwise, a global approach to the regulation of settings where our members work does not exist. So what we have found is in environments where there is a mixture of regulated health professionals and non-regulated health professionals, so they could be other health professionals who are not regulated or other individuals who provide administrative support or even our owners but are not health professionals, regulated or otherwise, is that if a problem arises that's not something that is in the direct control or even indirect control of a member, it's very difficult for us to affect any kind of meaningful change if there is actually a problem. We cannot have a non-regulated individual subject to as being the subject of a complaint or a discipline proceeding. We can't subject them to minimum requirements, of course, in order to be operating the clinic, etc. All those sorts of things that apply to members, of course, don't apply to non-members. Even if we had the power or decided to exercise the power to inspect clinics, which all colleges have the power to do under legislation, but many colleges like ours do not, even if we decided to go ahead and start inspecting clinics, again, there's only so much we can do because we can only directly require members to make changes or to meet standards. We don't have any sort of direct ability to impact the any practices that are not controlled by the member, and that can be certainly problematic. And we have definitely heard from our members that they do feel that this does occur certainly from time to time for members in their workplaces. So some of the areas that have been noted, and again, this is not just our college, this is all the colleges that have been participating, so some of these may apply more or less to dietitians, but certainly amongst all the professions they have come up. That there are these situations where there is a breach of standard, maybe even sometimes by our own members, where the member felt that they were powerless to do anything about the situation. I want to add a caveat here because I think it's important that we send the message that we know to a certain extent that we have the ability to require members to operate ethically and legally and professionally. And what we will tell a member if they call us through a practice advice service or otherwise and they're struggling with a situation within their workplace, we will help them work through the situation and provide some problem-solving ideas to address the issue with their employer or with a colleague. And ultimately, at the end of the day, if the problem is serious enough and the member is not able to affect any change, then our advice will be that they may have to leave that place of employment. We know that ultimately that this is an important message that members understand, that they do still have a responsibility to ensure that they are not violating their professional standards and ethics. But we know realistically that doesn't always occur, and as a result, there are public interest and public safety issues that are engaged in those situations. And sometimes, even if a member does eventually go so far as to leave the place of employment because they're being put in an impossible situation as a result of demands being placed on them, it could be some time down the road, and in the meantime, the employer has still done whatever it is that they've done that's problematic. And then what we also know is when the member may leave, that another member comes along and gets hired into that position, and it can take them some time before they realize or appreciate what is being asked of them and how the clinic is operating. And at that time, again, there are perhaps activities that are going on that are problematic. And the member, again, they go through the exercise of trying to address it with the employer, contacting the college, speaking with their colleagues, trying to problem solve through it, and then they may also leave. But again, I don't think anyone would agree that that's an ideal situation to have. If there was a body that could directly address the issue with the root of the problem, so being another colleague in the environment or the operator or owner of the clinic, rather than trying to get at the problem through our individual members, it would be much more effective than what the tools that we currently have available for us. So I think it's important that members appreciate that we are absolutely aware that members have obligations in this. And I don't think anyone would say at the end of the day that it's okay for a member to just throw up their hands and say, well, I tried and the employer didn't listen to me, so I guess I've done enough and I'll just have to keep moving along. No, we don't think that's acceptable, and I think many members don't think that's acceptable, and we're not suggesting that we're content with that sort of situation. In fact, it's quite the opposite, because we appreciate the impossible situation sometimes our members are being put in, and this is what we've come up as a possible solution to assist members with that, because ultimately we think it's in the public interest to do so. So some of the examples that you see here, I'd just like to go over just very briefly. So in some environments, the employers or the operators may have quotas or requirements that have particularly high patient volumes. And while quotas are not necessarily problematic in and of themselves, of course they do have to be managed and have to be appropriately set. And certainly some colleges have heard from their members that they feel quite a bit of pressure to maintain these high patient volumes in a manner that is perhaps not in the best interests of patients. And of course, that's directed specifically by the employer, by the operator, in order to enhance their financial position. There can also be, again, amongst some of the professions, concerns about supervision or others who are hired and placed in the clinic setting to provide services or assistant type services who are perhaps they're not qualified, so they're not regulated. There's some kind of assistant position. They're not regulated. There's not a lot of quality control. And again, while the member has some authority, if they are the person's supervisor, they ultimately are not doing the hiring, and so it can be difficult for them to manage situations of individuals with inadequate training or supervision. Record-keeping issues have come up, as well as billing issues, inadequate infection control, and abuse of credentials. And again, I think it's important to note that we appreciate the extent and the responsibility of our members within all of these sorts of situations, and certainly members do have some responsibility to ensure adequate infection control, that their credentials are not abused, that bills are correct and accurate and submitted in a timely manner. However, we do know that they don't always have complete control of these situations given the way that the business may very legitimately be set up. It might very well be that the member is not putting a bill in an envelope and mailing it out. So the extent and the impact that a member can have can be limited in some situations. So why should colleges get involved? It's a very legitimate question, because we are talking about not issues with our members per se, but issues with individuals that members could be working with or who are answerable to, that is creating pressure on members. And the short answer is because we know about it. Because we are the ones who have been best placed in the last 2 decades, really, to hear about these issues from our members. Oftentimes it's from our members, but also, of course, from members of the public who make a complaint to a college, only for them and us to learn that the person that they're complaining about, in fact, is not even a member, much to the surprise sometimes of the patient or the client. Of course, though, what we do recognize is that colleges do not regulate non-members, nor is that what's being proposed. Colleges, by definition, are self-regulatory bodies. So we regulate the professions, and we're not going to be proposing that the colleges get into the business of regulating unregulated individuals or regulating clinics at the clinic level. So you'll see as we get through the model that we're actually suggesting that it's another body that's created, another college, very similar to the colleges, that would be regulating the clinics. Another question that has come up, and it's a very legitimate question, is why colleges are getting involved, i.e., how big a problem is this? Why have we decided that this is something that we need to look into, let alone, get far enough along in the process that we're engaging all of our members with feedback? In all honesty, this is something that the colleges are still working on putting the data together. It can be very difficult with this type of issue to get substantial data, because, as we know, much of the problem is in fact not actually with our members. So we might not necessarily be getting complaints about the clinic at the clinic level, because if the individual who would have made the complaint is aware that the problem is not with the member, they're not going to make the complaint to us, so we would never hear about it. It's also difficult, although we are all in the process of doing it, in delving into our complaint and inquiry and concern information to try to tease out those instances where the problem ultimately was not with the member, but was more with the setting or the employer. That said, we do know that this is a problem. all of the colleges who are involved have identified in one way or another that this is a problem. We do have the benefit of 20 years of phone calls, written complaints, and just conversations with members and members of the public to know that this does exist. It's the extent of it and the pervasiveness of it that we are in the process of getting an even better handle on, because of course we think that that's important to have both for our members, and then in the event that there is a submission eventually that goes to government, we're going to need to have some data to go forward on. What I can tell you is, for example, this is just one of the examples from one of the colleges, is that in an area of concerns about business practices alone, the College of Physiotherapists has twice as many problems arise where the physiotherapist is not in control of his or her own practice. So based on their own analysis of their own data, they've seen that there are twice as many problems where the physiotherapist is not in control. So again, that's not across the professions necessarily, but it is just an example of, how this has come to the fore of colleges and the awareness of colleges that there is a concern here. To provide some assurance to members when we're talking about cost, because again, the question about why should the colleges get involved if this isn't something necessarily that's a problem directly with the members, and in fact we're not going to be proposing that the colleges take on the regulation at the clinic level. Members ask, well, why are we paying for this? What is involved? We here at the College of Dietitians, as I said, that when Council made their motion in October, we were a little bit later to the table than some of the other colleges that have been looking at this for closer to a year. We have not committed any funds at this point to the program, so it's just my time and Deb's time in order to reach out to all of you and provide the consultation materials and the other information. We haven't provided any financial commitment at this point. We didn't feel that we had the room in our budget to do so, and it was mid-year and we didn't feel comfortable doing that. So we do have the benefit still of participating as a full partner and being fully heard, but we haven't had to make a financial commitment. For those colleges that have had to make made the decision to make a financial commitment, and no college has been required to do so, it turns out to be about $2.70 a member so far for the colleges for all the work in all the preparation to date, as well as all the consultation events. So it's quite cost effective if you look at it that way. That's, I think, half of a Starbucks latte, and not even a grande one, just a tall one. Another question that has come up is self-regulation at risk? Because sometimes what people are hearing is, what we're saying is, there's a large gap in public safety and our members are running amok and we're not able to protect the public and we need another layer of regulation. That's not at all what we're saying. What we're saying is, we have noticed that there is a gap in some environments for some of our members when they are working with unregulated individuals. And the gap, we think, obviously is significant enough that the colleges needed to raise the issue and at least have the discussion about it. But we don't think that this is somehow an attack, or we should see this as an attack on the self-regulation of our members. So this was actual feedback by a member for one of the other colleges. I believe it was a physiotherapist providing feedback to the college that I still haven't paid undergrad debt. They've had to reject 5 places in a month. How many more jobs are out there? And the basis for this was because when they would go in and have an interview and start to talk to the employer about what the employer would want them to do in their role, they felt that they couldn't accept the position because they were asking them to do things that were unethical or unprofessional, or probably maybe not to the extent of illegal, but certainly were contrary to the members' professional standards. So there was certainly some frustration expressed by this individual member in trying to find an appropriate place. Not everybody obviously experiences this, and we don't want to overstate it, but this is part of some of the messaging that the colleges have heard. So what is some of the process that we have gone through and that we're going to be going through? So the first part, of course, was identifying the gap. This was raised initially by the College of Physiotherapists. This is something that's been on their radar for some time based on their own analysis and information from members and members of the public. So they raised the idea with other colleges to start the conversation to see if other colleges were noticing this concern or were having these sorts of issues expressed by their members and members of the public to them. So you could see the list of 13 colleges that have joined to date. So obviously some of those colleges have answered back that yes, in fact, they also do see, you know, to at least some extent, some of the gap that was originally articulated. So the partnership is continuing to build. Colleges like ours have been joining as the process has moved along. We developed a straw dog. So we're going to just jump into that in a minute to go over some of the details. And again, just to stress that that was so that we would have something for discussion, that we thought, you know, we are the regulation experts and we know in general how regulation works and how it needs to work, and also sorts of things that probably wouldn't work. So we thought it would be helpful to provide some type of concept that people could discuss, pull apart, put back together, give feedback on, et cetera, et cetera. There are a lot of details that have not been worked out yet that we're hoping to get some clarity on from the feedback and other discussions as we go forward. And some of it, even to the extent that some of the details have been sort of worked out in the straw dog, everything essentially is up for grabs, including, of course, whether or not we even go ahead. Big piece of that has been, of this whole process, has been consultation. The consultation started very early on, particularly for the colleges who have been involved for some time, and then just by the working group in general. Initial discussions with the Ministry of Health and Long-Term Care. The associations have been brought in by the various colleges, including Dietitians of Canada. In fact, right after this webinar, Deb and I are rushing off to a meeting with a number of the associations and the colleges to do something quite similar to this, where we're going to go over, again, the details of all of this, and then have a conversation amongst all the associations to get their feedback and to hear their comments. And then, of course, all the consultation with members that we've been doing over the last few weeks and will continue to do right through to the end of the month. And that will be ongoing as well. We will decide whether or not to revise or discard the straw dog, depending on the feedback. And then the ultimate decision will be whether or not we're going to be proposing anything to government, or perhaps that's not the route that we want to take. Maybe we drop the idea altogether, or there is another avenue that's identified as perhaps being more appropriate. Just to add to that, initially when the colleges did start to look at this, they did look at other alternatives to the model that we've put together, the proposed model, and it was identified early on that this is probably most likely to be the most effective and least intrusive and least duplicative. However, again, right from the beginning, it's always been the intention that everything is on the table and anything can change depending on the feedback. And just a final note on that, 35% of the feedback so far through the survey has been from dietitians. So you're a very engaged group, and if you've already participated, thanks so much. If you haven't and you're interested in doing so, then by all means, please do so. So the straw dog, what does this potentially look like? So we have right now all the different health colleges, and they are all obviously based on the names of the professions. Why break something if it's working? So this would be called the Health Clinic Authority. I think the name's probably pretty straightforward. It would have a duty, just like all the other health colleges do, that's set out in legislation, and the duty of the Health Clinic Authority would be to ensure that Ontarians are receiving healthcare in safe clinics. Pretty straightforward, probably pretty hard to argue with ultimately as a goal, and that's what, again, we're looking at. And it would have the authority to set standards, and ultimately all of this is intended to encourage and achieve public protection. So this health clinic authority would develop standards that all clinics would be required to meet. These would include registration requirements and standards for safety, for delivery of care, and for business practices. It's important to note that the intention behind the model of creating a health clinic authority would be the health clinic authority would have jurisdiction and would cover all members who are working in environments that are covered off. So what you're going to see is we have come up with a couple of proposed definitions for clinic, which by no means necessarily just a physical environment. And it wouldn't just be members of those colleges that are part of the working group at this point. So even though, for example, physicians and nurses are not at the table actively participating, if nurses or physicians work in environments that would be covered within the definition of a clinic, they would also be covered by this. But the idea is we wouldn't cover any environment or any individual who's already fully regulated at the sort of clinic level. The successful model, regardless of what it looks like and regardless of what this health clinic authority looks like, will not double regulate any entity. So again, I think it's important that members have that message. Some people have argued, and certainly we've heard feedback, that the added overhead for members would trickle down to the health professionals who will be paid less, and that may also trickle down into the fees that are charged for health services. So that may very well be the case, and it is definitely part of what we are looking at as to the viability of clinic regulation. So it's certainly something that we are aware of, would certainly need to be managed. On the other hand, what we do know is the overhead for clinic regulation will be kept as low as possible. The model does not contain all the features of health professional regulation. So if you're thinking about the standards that you are required to meet with respect to participating in initiatives through the college, so peer and practice assessments, your SDL tool, all of that data that you're required to input on registration and renewal, it's likely not going to be looking at just an identical model to that. It's going to be something that's specific to the needs at the health clinic level. And so we are looking at having something that is simplified and has fewer processes. And there, as a result of that, we anticipate that the cost should be lower on a per member basis, certainly than the cost of running a college. We anticipate that there would be a fairly minimal annual registration fee for each clinic. So there would be an initial application fee, not unlike what members have to do in order to become members, and then there would be an ongoing annual registration fee. But we don't anticipate that it would be much higher than what most health professionals are currently paying. And again, it would be at the clinic level, not at the individual member level. One of the aspects of the proposed model is that it would entail inspections, which would only arise every 3 to 5 years, and there would be a fee for the inspection. But again, the fees would be kept as low as possible on a cost recovery basis, and they again would also only be every 3 to 5 years. So it wouldn't be an annual expense that the clinic would have to incur. Okay, so the proposed model, so on the left-hand side there you can see the model for members or practitioners. So members of all the regulated health professions fall under the Regulated Health Professions Act, and it regulates people. With the clinics, the proposed legislation is called the Regulated Health Clinics Act. Again, why reinvent the wheel? And it would regulate places. And places should probably be in quotes, because we also do appreciate that many people work in virtual environments. Certainly some of the professions, some more than others, are very conducive to working completely virtually, either over the phone, over Skype, that sort of thing. And so this is intended, whatever the definition is and of how this would be applied, it is intended that it would apply to any of those settings, so that it's not just covering physical clinics. So if you think of a clinic as being very much a bricks and mortar location, then try to put that aside to a certain extent and think about more health, professional practice, perhaps, rather than a clinic. So this would be looking at regulating the practice. So there's a couple of proposed definitions that we're looking at to define clinic, because this ultimately is the cornerstone for what we would be regulating. If we're going to be regulating clinics, then we need to have a pretty good understanding of what that's going to cover, and just as importantly, what it's not going to cover, so that we make sure that we don't inadvertently create gaps or continue to have gaps, but again, so that we also don't have duplication for those settings or environments that are already covered off by similar legislation. So one of the proposed definitions is any location where a regulated health professional is responsible for the delivery of healthcare services. There are some weaknesses that have been identified potentially with that, to the extent that we would need to flesh this out a bit more and put some caveats. One of the concerns is that what if you don't have a regulated health professional responsible for the delivery of healthcare services in that location? Would it mean that they wouldn't be subject to any of the regulation, or would it mean that an unscrupulous employer would just then have the ability to get rid of their regulated health professionals so that they wouldn't be covered off? So then the other possible definition that we're looking at is any location, and again, location, please put that in quotes, because we're not necessarily talking about a physical location, any location where healthcare services are delivered or performed. And you can see, of course, this is very broad. It would mean that we would have to define in a meaningful way healthcare services, because what we are not intending to do is to add scope to the current scopes of practice that our members have. So to the extent that there are healthcare services out there that are performed that do not fall within any of the scopes of any of the regulated health professionals, we're not looking at adding that to this. We are again looking at trying to alleviate the pressures put on members in these environments. So if there has not been and will not be regulated health professionals working in that setting, because the type of service that's provided is not something that's provided by regulated health professionals, that's not what we're looking at covering off. So a large piece of the consultation that we are actively seeking feedback from our members about is on this, and to help us to get to a place where we feel that we can comfortably define what the parameters and what the borders will be of the clinic regulation. We know that this is probably the hardest part of the task to date, and probably will be going forward. We don't think it's impossible, but we do think it requires careful consideration as we go forward. There will be some exceptions. As I've already noted, we're not intending to cover off those environments that are already fully regulated, for example, pharmacies, hospitals. There may be parts of a hospital that would be covered because they might physically be a practice or professional service that resides within a hospital building but is actually not part of the hospital service and might not be covered off by the hospital legislation. If you're running some kind of clinic and you're using a space in the hospital, so it might be covered off by that. But certainly the nuts and bolts of what hospitals do, to the extent that that's covered off by separate legislation, wouldn't be covered. Pharmacies and out-of-hospital clinics and other sort of settings that are otherwise covered. We're also not looking at covering members that are completely covered off. So some of the feedback to date, and certainly some of the initial discussion amongst the colleges before we even went to the consultation, suggests that clinics where regulated health professionals are the owner or the operators, or where they are working completely on their own, they may not need additional regulation by the clinic authority, the health clinic authority, because you're already covered off in those circumstances. We need to still push that a bit more and make sure we've poked whatever holes we can to make sure that there is coverage, sufficient coverage to ensure that that would be a legitimate exception, but it is something that has been identified as likely falling within one of the exceptions. So some of the requirements for the registration, for the clinic registration is the clinic would have to designate a principal representative. We're looking at whether or not the principal representative must be or may be a regulated health professional, and again that's one of those details that we're still looking at. But the principal representative, regardless, would have to demonstrate good moral character, which is something as well that members of the various health colleges are required to do upon initial registration. And this is so that the person who is responsible for the clinic, who's responsible to the health clinic authority for the clinic, would always be someone who understands professional regulation and the obligation to meet standards. There would be a public register, not unlike what exists for members of all the regulated health profession colleges. It would include details of the clinic, including the address, etc., the names of regulated health professionals and links to their college's website, so that if you wanted to look up additional details about the individual regulated health professionals who work in that clinic, then you would click on that and it would take you to their respective college's website for further information. It would include non-regulated providers of healthcare services within that clinic, inspection dates if the clinic has gone through an inspection and the outcome, and the status of the clinic's license. So again, similar to what we have already on our websites for members. Unregulated clinics would be prohibited from providing healthcare services to the public. So absolutely, some of the feedback that comes up, and definitely a big part of the conversation that the colleges had beforehand, was how do we ensure that clinics don't just go off the radar, or that they just decide, well, I'm not going to become registered and I'll just continue along my business and I won't hire any regulated health professionals to provide my services. That's more concern certainly for professions like dietetics and other professions where they're not heavily involved in controlled acts. And so there is a risk, obviously, and there are, as we know, individuals out there who can provide similar services to what some of the regulated health professionals do. And the intention is not that we're going to create sort of a two-tier system or to create a system that will cut out regulated health professionals from the provision of healthcare services, because we do strongly believe that there is value to having regulated professionals providing services to the public because of the high standards you've had to meet to become registered and the high standards that you are all kept to as you maintain your memberships. So this is an important piece of it. What it means is if you are not a regulated clinic, you would not be able to provide healthcare services to the public. So it would be like not unlike an unregulated individual using one of the protected titles, so dietitian, pharmacist, registered massage therapist, et cetera, or certainly for those professions that have controlled acts, communicating a diagnosis, et cetera, the unregulated clinics would not be able to participate in those kinds of activities, which would then give the clinic authority some leverage to enforcement against unregulated clinics should they decide to operate outside of the scheme of the regulation authority. There would be an inspection program. This is really the cornerstone of the requirement for the standards and ensuring the standards are met and for enforcement. It would be the main tool for ensuring that the clinics are meeting their standards and are safe for patients. So these would be on-site inspections, and again, we'll have to look at what this will mean if you're talking about people who are practicing in virtual settings. Part of it may include an inspection of somebody's home office, but perhaps more importantly, what we're actually talking about is an inspection of billing practices, advertising, that sort of, communications they have with their patients, that sort of thing, which isn't necessarily going and looking at equipment. Not every profession deals with equipment. In addition to regularly scheduled inspections that all of the clinics would be subject to, the health clinic authority would also do an inspection in response to a complaint or a concern. So again, not unlike how colleges regulate members. Of course, the inspections committee would have to have some teeth. So they would have the ability to suspend or impose restrictions on a license. They would have the authority to refer concerns about a regulated health professional to the individual college. So if in the context of an inspection, a concern about a particular member actually came to the attention of the inspection team, then that information could be shared directly with the college of that respective member so that they could address it directly with the member in appropriate circumstances. And they would also have the ability to make emergency suspensions. Again, this needs to have some teeth, and we have to have the ability to enforce the standards on clinics in order for this to work. So clinics will be required to display the clinic license and inspection outcomes at the premises, and they would be required to submit regular reports to the clinic regulator. Now, an important question that has come up at one of the town halls, and that the regulators did discuss early on in the discussion about clinic regulation, was how do we avoid creating a two-tier system inadvertently through the requirement to display clinic licenses and inspection outcomes? Because as you might recall, not every clinic setting necessarily would be covered by this regulation, and quite legitimately. So they're not covered because they're already covered off by something else. However, would it start to be something that patients would look for in a clinic setting, that they would look for the license and they would look for an inspection outcome, so that if they come across a clinic that doesn't display a license or doesn't have any kind of inspection outcome, would that be seen negatively by members of the public? Would they not understand what that meant? Would they think that that was a clinic perhaps that was operating under the radar, or at the very least just wasn't subject to any sort of standards? And that's not the intention, and so we don't have an answer yet on how this would be addressed, but it is something that we are aware of, and it is part of the conversation and the discussion. Certainly if anybody has a great idea for how we could address this situation, we would love to hear it. Another piece, of course, would be that employees, in particular members of the colleges as well as non-members, would have the ability to raise concerns about the practices of their employer or their operator without fear of reprisal. So there would be whistleblower protection, which is becoming more and more common in legislation and in settings, as we appreciate the benefit of people being able to raise concerns without having a negative impact on their job situation. So that is absolutely one of the components that we are looking at incorporating into this. The health clinic authority and the individual health regulators would work together to ensure appropriate oversight without duplication of regulatory activities. So we would have the ability to share information back and forth and to coordinate activities, and to also to avoid duplication. Just as the health clinic authority would report concerns to us, we would report to them. So what would this mean for health professionals? It would mean that the practices at the clinic level would be better aligned with professional standards. Certainly in some environments, it's no doubt the case right now that the practices at the clinic level are aligned with your professional standards, and that's great, but it's not necessarily a given, and this would require that. It would require appropriate screening and supervision of assistants if that's part of one of the components. It would have more transparent billing and safeguards against abuse of credentials. And clinics would be required at the clinic level to keep adequate records and to ensure that patients and other healthcare providers can have appropriate access to those records. And then, of course, you would have the ability to raise concerns without fear of reprisal. And you would also be able, what we're also hoping, of course, is that this would empower members to go even further, or to feel more comfortable when they do need to raise issues with their employer, that they have the voice of the clinic authority and the legitimacy and the credibility of a regulatory body behind them when they go to their employer and say, you know what, this isn't okay, we need to change how we're doing things here. What would clinic regulation mean for patients? It would mean that they would get information needed about clinics to make decisions about care. So much like the transparency is seen about members as being valuable to patients so that they can have that information when they're choosing who to go to. This would be also information that, additional information that patients would have about their clinics. There would be standards and inspections to help protect patients' health and safety. Clinics would be required to keep adequate records and protect privacy, obviously very important for patients. Again, the more transparent and accurate billing obviously would be very much benefit to patients, and they would have a way to report clinic concerns to the regulator, because you can imagine how frustrating it must be for a patient who has a very legitimate concern about something. They come to a college only for the college to say, we're sorry, but there's only so much we can do, or in fact there's not really anything we can do, because this issue is not actually about our member, it's about the owner or operator, and even the ability of our member to address the situation is quite limited. What would clinic regulation mean for clinic owners? So some of you out there may be owners or operators of your own practices and wondering what would this mean for you. It would mean that you would need to register, you would have to apply, meet the registration requirements and register. You would have to maintain the standards expected of the clinics. You'd be subject to periodic inspection, and there would be a registration fee and inspection costs. Certainly for anybody who's already a regulated health professional, this is going to be very similar and very familiar to what you already deal with, and will not be as extensive. So on that front, I think that's certainly good news for members. For those owners and operators who are not members of the profession, it obviously will be a different situation, but certainly the concept of having to register a certain aspect of their business will not be new or novel. Certainly owners of businesses have to register for HST. They have to register to submit their employee tax deductions if they have employees in that way, if they're providing services through WSIB or that are covered by OHIP. There's registration requirements and standards that they have to meet. So this is certainly not novel in that sense. It is just another piece. So that is all that we wanted to make sure that we covered off at this point. Do we have any questions or even any comments that people would like to share?
Yep. So I have a couple of questions that have come in, Melissa. So I will read one that has said that, how will unregulated clinics be prohibited? Many of these people operate out of their home.
That's a good question. So part of some of the mechanics of this will have to work out, but it will be quite similar to right now how it works with members. So in part, we do work on a complaint or report basis. So if there is somebody out there who is calling themselves a dietitian who's not actually a dietitian, then we may hear of that from another member or a member of the public, and then we have the ability to address that. So that is at least one of the ways in which the clinic authority will be made aware of unregulated individuals who are operating outside of the legislative scheme. And there may be other mechanisms that they use. Obviously, they're not going to be just randomly going into people's homes to see if they're providing services. But that is one of the ways that colleges do it currently, to be made aware if there are individuals at least who are practicing, we call it illegal practice or unauthorized practice, and that's intended to be one of the mechanisms. There may be other mechanisms if we cross-reference perhaps with billing agencies. So anybody who is billing a third-party provider but is not registered as a health clinic authority, then they may also be captured in that regard, and the health clinic authority then would have the ability to raise it with them.
One other question was about whether or not the model for clinic regulation would address when, as an example, a pharmacist may hire a non-regulated nutrition provider to provide nutrition education. So will there be a process to inspect that, the practice? And if I can start to answer that question, and please, Melissa, feel free to add to this, is that the clinic regulation model would not deal with scope of practice, as Melissa had mentioned earlier. And in the instance when something is in the public domain, such as the provision of nutrition advice, the model itself would not actually dictate who the pharmacist may be permitted to hire, but we would certainly encourage the health professionals, for instance, a dietitian, to educate those pharmacists on the difference between a regulated and an unregulated nutrition provider. And certainly they are willing, or they are more than welcome to share the college resources, such as the videos we have on this subject. One question that came up just throughout the presentation was somebody had actually had an example of a clinic that was not fulfilling or not meeting the standards of the profession of dietitians, and despite the dietitian's advocacy to have changes, this particular dietitian wished to leave the practice and wanted to know whether the college would like to be informed of either the clinic name or perhaps even the issues that were addressed or the dietitian tried to address in the advocacy efforts.
That's a good question, and that would always be valuable information, and certainly within the context of this consultation it would be very helpful to hear from members if they are grappling with these kinds of situations and would not otherwise have brought it to the attention of the college. So by all means, I would invite people either through the survey to provide that feedback, or if you'd like to directly provide that information to the college, then reach out to us and do so. You are welcome to do it on an anonymous basis if you feel more comfortable doing that, or otherwise. So yeah, no, we would love to hear that.
Next question was, would clinics where only regulated health professionals operate be exempt, as they are already individually regulated by their colleges?
Yeah, so that is, yeah. So that is one of the exceptions that we are looking at. We don't know at this point if it would be if you are just practicing on your own, or if it would be if the entire practice is regulated health professionals, or if it would be in the event that the owner or operator is a regulated health professional, but there are non-regulated individuals who are working under that owner or operator. So it is certainly contemplated as one of the exceptions, and for the reason you've noted, because they are already covered off by the college requirements.
Okay, next question. Will you provide this information to the institutions that provide courses for some of the non-regulated nutrition providers? For example, schools that provide certification for holistic nutritionists. So I'm assuming that the question is about whether or not the proposed model for clinic regulation will actually be provided to the schools that deliver education to holistic nutritionists, and then, of course, subsequently they would be informed of the actual regulation of the health clinic if such a model would be put in place.
Mm-hmm. No, that's a great question. It wasn't something specifically that we have contemplated as a possible stakeholder at this point, but we will absolutely note that and see if they, in addition to others similar along those lines, should be informed and solicited for feedback, but also so that they're aware of the potential change in landscape going forward.
Another question that came in: why not regulate the non-self-regulated health professions? So why not try to regulate all the non-regulated healthcare providers now, rather than, I'm assuming, regulate the clinics themselves?
No, that's a good question, and again, it was something that was discussed early on by the various colleges, in particular by those colleges where this is more of a live issue than it is for some of the other colleges. Some of the colleges, like dietetics, do have another group of individuals who provide very similar services who are not regulated. So for example, the nutritionists and some of the other professions have similar situation with a group that provides very similar scope of services, but they themselves are not regulated. And of course, with some professions, there isn't really a similar sort of other cohort. Mostly because those other professionals are so heavily involved in controlled acts that they don't have a group of unregulated individuals that are permitted to also legally operate. It was decided that while there may absolutely be issues and concerns and other sorts of challenges with respect to just in general unregulated individuals providing healthcare services, that this at least was not going to address all of those other issues and was not intended to address all of those other issues, that there may be another way of getting at that. Will be partially covered off by this, but this is by no means intended to be the full problem solving for that. What we do know from the Ministry of Health and Long-Term Care is that there is not a significant appetite there to expand self-regulation to other professions. So that has been a message coming from them in some of the decisions that have been made in the last couple of years. So even if we were to go forward, for example, to suggest that a scope similar to dietitians was to be regulated, it's unlikely that that would have a lot of legs with the ministry at this point.
Okay, there's a comment that said it sounds like you are proposing regulation of employers or owners or operators of clinics and not locations or places.
So I think that's probably a fairly fair characterization at this point. It's not intended to be, again, solely bricks and mortars locations. Now, some of the requirements within the inspections will be, to the extent that it is relevant in the situation, would be a physical inspection of a premise, which could include, for example, infection control practices. But we have absolutely recognized pretty early on that not every practice has a physical location in that sense. And certainly not every practice is going to have equipment or otherwise things that need to be inspected, for example, because of relevance to infection control. If you're doing all of your services over the phone, all of your counseling, if that's the service that you provide, is all over the phone or through Skype or something like that, then obviously the concept of infection control practices is not relevant to you. Equipment maintenance and whatnot is likely not relevant to you, so that part won't. So we're still trying to sort out what's the best way to articulate all of this, and maybe clinic at the end of the day is not even the best word, but it's not intended just to regulate the individual owner-operator, but it is intended to be a mechanism for us to get at the owner-operator to be able to affect change or at least continuing standards going forward. So I'd say it's probably a combination maybe of what you've said, where it's regulation of the owner-operator and also regulation of the clinic, whatever the clinic happens to look like in that situation.
Okay. So it sounds like the model or the proposed model will restrict unregulated clinics in providing healthcare services to the public. So if they're not a licensed clinic, then they can't provide healthcare services. And would this include clinics that do not contain a regulated health professional?
So a very important piece of this will be defining what is meant by healthcare services. So I don't think the intention is that we are going to be essentially turning activities that are not controlled acts, and I don't know if everybody knows what I mean when I say controlled acts. So that's those very limited acts or activities that are set out in the Regulated Health Professions Act as being only things that certain identified regulated health professionals can perform. So I said earlier, communication of a diagnosis is one of them. It's not, the model is not intended to expand that list of activities that can only be performed by certain regulated health professionals. So how we define healthcare services is going to be very important. We don't know exactly what that's going to look like, but again, it's not intended to expand that model. But what we are intending to do, though, is, again, to not create a two-tier system where an owner or operator can just cut out regulated health professionals and continue to provide the healthcare services that they were providing, but then operate outside of this regulation. And so we're trying to figure out what is the best way to articulate all of this so that we don't have that result. One more.
So just looking at, well, I think we have time for about one more question. And this is someone's, in their experience, the clinic, if the clinic was going to be inspected by the College of Physicians, they ran around preparing a standards binder, but they passed, and everyone went back to sort of what they did prior to the inspection. So how would, I guess, would the clinic ensure that the standards are actually continued in the long term? Perhaps would random or surprise inspections be considered?
So in addition to the regularly scheduled inspections that clinics would have to undergo, there would be a mechanism for individuals to report concerns or complaints to the health clinic authority that would then trigger an inspection. The concept of random inspections hasn't been part of this, but it could very well be something that comes up. So in addition to the set number of scheduled inspections that would occur in the year, perhaps a percentage, there would be an additional percentage of random inspections that would occur to make sure everybody's kept on their toes for that sort of thing, but also in any event, there would be the mechanism for individuals to bring concerns to the attention of the college of the regulator, so that they could then raise that with the clinic. Okay, we'll take one more question.
Sorry, I think this is an important one that probably many dietitians are asking about. So this is an unregulated clinic will be prohibited from providing care. However, an unregulated professional could work at the clinic so long as the clinic meets the standards. So won't this mean that we'll start to see nutritionists or the non-regulated, so non-dietitians working at regulated clinics as a means to get around this?
So one of the, and again, this was definitely noted by some of the colleges early on in their discussions, and in particular it was raised by those colleges who do see this as a possible risk because they have, again, this other cohort of individuals that provide very similar scope of services to the members. And again, it's not intended to, we don't protect members, we're not the association, but we do absolutely see the value of members providing services because of the high standards you have to meet and the high quality of which you must continue to provide services. So the intention is absolutely not to push regulated health professionals out of healthcare services altogether. One of the mechanisms that's being looked at is whether or not it would be a requirement for regulated clinics to have a regulated health professional either as the responsible person, so the assigned responsible person who would be the contact person with the health clinic authority, or otherwise providing service within the clinic. It does recognize, though, that there absolutely are services that can be legally and legitimately provided by unregulated individuals, and it's not intended to otherwise to cut that aspect out for patients. But we are looking at, how far can the health, or should the health clinic authority legitimately go in ensuring that there is some involvement of a regulated health professional in order to ensure that the minimum standards and quality are met. Okay, so I think that is all that we have time for. I've noticed that our attendees have dropped off quite a bit from 1 o'clock. Thank you, all of you who have joined. Again, we do have another one on Thursday, so if you have any colleague who's interested in participating, then please encourage them to sign up for that. Do the survey if you haven't already done it. Feel free to reach out to us here at the college, either Deborah or myself. You can directly get in touch with either of us because we would like to further hear from everybody. So again, thank you, all of you, and happy holidays. Hope at least some of you are able to take some time off and enjoy the holidays with your friends and family over the next couple of weeks.